webinar, the fourth in our series, the final one in our current series, Developing Effective Supervision Practices. We have a few fewer slides than in previous ones, but I have some material to share with you as I talk through the slides. So we'll have a lot of material to discuss, and we'll be on the lookout for questions that are passed on to us that I will share with the group and hopefully try to answer. And this first slide is me. I'm a licensed psychologist. I'm the Vice President of Innovations at ICL, coming to you live from ICL right now. And among the things in terms of my background, prior to my starting at ICL, I was Chief Clinical Officer in a managed care company, so I will share some perspectives from that realm as well in terms of the perspective of what the MCOs might be looking for and give you some idea about the kinds of things that would flag their attention so you can be prepared and be one step ahead of those kinds of things. In terms of our learning objectives for today, we just wanted to put this up in terms of understanding supervision in general, the considerations of supervising staff, and to think about this as an extra layer on top of already strong clinical supervision. And as we go through it, you may be thinking about some of these ideas in terms of what your staff supervisor might do, and also some things that your clinical supervisors, clinical leadership might be kind of rolling into their consideration as we go live in New York State with managed care as well. Learning from the experience of other organizations in terms of things that I can present to you, and for any interaction that people may have as they wish to call in and share any of those things, and for us to ask questions that will help to clarify the way forward as we go into our brave new world of implementation. And just before we start also, I know that in previous webinars, one that I had conducted, one that Boris had conducted, it's come up about the algorithm for how many staff to the size of clients served, et cetera, and just wanted to tell you again, there is no definitive algorithm about that, so people will have to make those choices. So we're talking in some respects here about qualitative things to be considering as opposed to the quantitative things, but I do hope that those things will be helpful as we move forward. Okay, and also wanted to just include this again. We had shared this the last time, but in terms of how should a provider think about the practice of sometimes people think about this as burdensome or frightening, or you put on the adjective that you wish, but there are things about the whole process that can be very positive, and as we like to be strengths-based, let's think of it from this perspective as well, that the feedback from an MCO can assist in informing our own practice changes, because we're all about, together, interested in improving outcomes, to ensure that there's effective utilization management, so there's a flow of funding for services being provided, there's no lapse time or time spent chasing down authorizations to make sure that happens, and that the utilization management helps to focus our attention to better understand the population and be thinking about some statistics and data about our particular populations that we serve, and if we have niche populations as well. Those are things to think about in terms of quality improvement perspective as providers also. Okay, and these are the different kinds of things that MCTAC has talked about with regard to different tools, and among those things which have been also sent in previous emails, we have the job description for a supervisor, the person who would be helping your staff and keeping them on track and helping them develop their skill set as well. So those are the things particularly we're going to be talking about today. Okay, and in terms of the checklist, which covers any number of things that we have, as we go to the next, the thing that's highlighted in red, the supervision, that's what we're really going to be talking about today. And also, as we talk about supervision, I think certainly we're talking about the strong supervision from a clinical perspective, but also as we talk about the piece here with the supervision, that supervisor also has to bear in mind some of the business aspects of utilization management, particularly in terms of the authorization requests being filed on time, looking at turnaround time that's being requested per MCO in terms of that, if appeals are going to be filed, all of these kinds of things. So these are things above and beyond the clinical piece that these folks really need to bear in mind and have some oversight of as well. So just bearing that in mind. But as we look at the checklist, certainly select or hire well-qualified individuals to supervise the staff. So we're going to go into some more detail about what some of those variables might be, but certainly one of the things that I would suggest here is that person should be well-seasoned. This is someone who should have some strong clinical experience and some experience in being a supervisor as well. This is my personal editorial, but just given so much that's riding on this, this is not the ideal position for someone new to a supervisory role. So someone who has some experience with that would probably be best, though certainly different kinds of experience can be taken into account. But this is someone who's going to have a lot of responsibility put on them, so you might want to just bear that in mind as you consider people who are going to fulfill that role. Okay, so now we're going to show you the supervisor position description, which is a very busy slide, I will say. So look at this as a sample, but in our next slides, we've really culled out these pieces so you don't have to get eye strain looking at all of these different bullet points. Let's look at them in the next two slides and talk about them in some greater detail. And these next slides are also, as you can see, rather, as Oscar Wilde would say, crowded with incident, but we'll take it one step at a time and start to plow through them and see some of the things that could be discussed in general. So I'm going to look at these bullets one at a time here with you. Okay, first one here, providing day-to-day supervision of your staff, such as making case assignments, assuring coverage for the upcoming reviews. Those are the supervisory/business kinds of things that I was talking about. In terms of these are the kinds of things that this person really needs to be on top of and make sure that they're happening, et cetera. And also to make sure that there's backup coverage, because we know that your staff are going to be taking vacations and a variety of times they're not going to be available. So you don't want the authorizations to languish, or things are not happening within those time slots. So just to be sure that the supervisory type person has that under wraps as well. And the weekly supervision, it could be individual, could be group, might be considering both things. Certainly to be available for individual issues as they come up, and some of those things might have some urgency to them in terms of time frame or the clinical need as well. So just bear in mind that that person probably needs to have an open door to be available for those things. Also suggestion here to hold case conferences to review cases and to develop the strategies to managing the cases. Find the threads of commonality among the kinds of cases, the kind of issues that are coming up. So this person in the supervisory role can kind of track that and see what particular areas of need there may be as well with that. This may be also the forum in which staff can be coached to learn how to present a case, to do it in a very effective, cogent manner, and also to be doing it within time constraints so that the case, when it may be presented to the MCO, doesn't meander all over the place. It's very focused, and this might be a good thing to be able to do in-house. Reviewing records to assure that the case plan strategy, care plan strategies, and the transition strategies, everything is meeting agency expectations. So really, in thinking about that, a lot of this feels very QA-ish. And there really is indeed some overlap with these functions. So to think about how that's organized for you as a provider and how that QA piece matches. But I would also suggest it's the place where you can move from QA to QI also in terms of seeing what things you want to develop, what particular projects you might want to take on to make improvements in that regard as well. Periodically listening to the calls. that take place between the UM staff and the MCOs in terms of appropriateness of the conversations. Certainly, are they effective? Are they relatively brief? I mean, are we getting to the nub of the matter as you know, in the appropriate time period? And I would think if you're looking at some of the UM staff, if they have less experience, of course, those are the people that the supervisor may want to spend more time listening to and just making sure people on the right page if they need particular coaching, or if there have been any concerns expressed, whether that's an internal piece or if that's come to the supervisor's attention from the MCO as well. So, of course, you know, that's kind of basic supervision in terms of following up, but that's perhaps where that effort is going to be spent particularly. The supervisor also maintains the routine, productive channels of communication with the MCO, UM departments, the people who are you're contracted with, and seeking feedback on the work of the agency. So certainly the supervisor needs to have the pipeline to the right people in the MCO with that. So your supervisor is going to be an important person because they have that contact information for the people to contact if situations arise, or again, there's a time-sensitive situation, and has had some kind of a relationship with these folks as well. And also be able to get some formal and informal feedback, just, you know, kind of the check-in, the old Mayor Koch, how am I doing kind of thing. It's probably not a bad idea. And if there are any kinds of issues expressed, any kind of difficulties, to certainly be able to address these things immediately and not have things linger or things to, you know, kind of pile up on top, to address them as they come up. Also, in terms of the supervisor's role with the MCO, so this person may become aware of any work groups or situations the MCO is looking for a provider or contractor feedback around clinical issues per se. So that's maybe something the supervisor wants to be alert to, or certainly as they get that information, feed that into clinical leadership with the provider, with your agency, and get someone on board. Because if there's ever an opportunity to meet with the MCO on those kinds of things, you definitely want to take advantage of it and have someone at the table for that. To maintain the understanding of the UM practices and the related expectations for each MCO. And we would like there certainly to be some uniformity to this, but we can't predict that. And there are going to be some differences, some subtle, maybe others not so subtle, with the different MCOs. And so the supervisor needs to really be aware of that in terms of practice and culture of the MCO as well. Training the UM staff on current UM practices, certainly making sure also that any changes in policy or changes in benefit plan or criteria that the MCO puts out are disseminated quickly to the staff in your agency as well. So it's not the kind of thing that you want to find out, that people want to find out a week later. So as soon as the MCO were to get that, and so the supervisor needs to be in the loop that these kinds of things are disseminated, they're discussed among the staff so everybody is aware as well. And these are also places, in terms of this training, to speak to the opportunity for clinical integrity within the agency. And by that I'm talking about things like making sure the diagnosis and treatment interventions, that they really match in terms of that, in terms of best practices, et cetera. Again, thinking ahead of the MCO, thinking about what the MCO might be drawing attention to or be concerned about, so that the UM folks are originally flagging it and asking the actual clinician what some of these things might mean or how do these things really work as well. It's also the place to speak about the evidence-based practices, coaching, finding out what other kind of internal training you may need on this, talk about things like advanced directives. Do your clients have those? Are there things that have been discussed? All of these kinds of things could be on the radar, and it's really within the supervisor's purview to gather that information, to help hopefully do that training, or find someone else within the agency who can help and to assist perhaps with that, with the direct training, mentorship, feedback, et cetera. Developing internal workflows in terms of any schedules, et cetera, with designated responsibilities for the timely reviews. So you definitely want to make sure that you can track when authorizations are going to need to be submitted. How many more sessions do you have? How many more do you go? What's the timeline in which the reauth can be submitted as well? Another thing to mention, we're being, as providers, very concerned that we're responding in the timely manner and within the window that's given to us by the MCO. You might find that you have some concern that you're sending things to the MCO or a question perhaps has been submitted and you haven't heard back. So again, the supervisor needs to know who is the crucial person or are the crucial people who can assist with that at the MCO. And if they're just not getting any kind of response for this, and again, if we're looking at time sensitivity, to whom can they bump up this concern? Who's the next person in the chain of command who can look into this and get you the answer that you need as well? It really is a two-way street, and that's always something that I like to emphasize on that. Because when I was with the MCO, I certainly would hear at times if some people in my division weren't acting on certain kinds of requests, and so I would hear about that. So those kinds of things are possible. Continue looking for process improvement opportunities. This is what I was talking about before. Some of the things are in terms of QA, in terms of are things in place, are things there that should happen as expected, but also taking it the step beyond. And certainly in terms of accreditations, we're always looking for QI projects as well. And certainly this could happen around the process. So look at that kind of thing. And that's always something that you can share with the MCO. We've become aware of this as an issue. We want to improve on this, whatever this might be. And so this is an internal QI project that we have. And being a member of the agency's leadership team. And I know different agencies are going to have different constituency in terms of their leadership. The important thing is to be able to report back on successes and challenges with every MCO with whom you're contracted, and also to share with leadership any feedback about any agency, I'm saying internal agency barriers, silos, personnel issues that might be coming up, etc. So again, these are things, if you have any challenges internally, you definitely want to discuss it and think about problem solving internally as opposed to having the MCO come to you or come to your leadership and be talking about these kinds of things are an issue. So be aware of those kinds of things in advance. Okay, now our qualifications about the supervisor. The person should be a professional with certification or expertise, licensure in their specialty being reviewed. Now, we had some discussion about this last time with staff about RNs. And some people have RNs as their staff and their supervisors, and RNs are great clinicians. They're often very well suited because of their expertise in physical health as well as behavioral health as well, although particularly we'd be looking at RNs often with psychiatric behavioral health expertise as well. But just want to emphasize it does not necessarily have to be an RN, but RN should not be excluded from the pool also. But I do think that it should be someone ideally who's a more senior clinician, who has been around the block, who knows these kinds of things, can address the clinical issues, and has the wherewithal to address some of the responsibilities, et cetera, that are coming down the pike along with this. Experience with practices, so certainly having a good understanding of what's required for a good handle on the processes and protocols that go along with that. I think that someone who's in this situation with that experience and expertise should be valuing person-centered recovery-focused processes and practices, but beyond that can help the staff, whether that's in or in feedback to clinical staff, can help people learn to incorporate these principles, and in terms of documentation, make sure these things are in there as well. as well as the medical necessity. And it is possible to have all of these things operating simultaneously. It may take a while for some of that knack to be acquired, but it can be done with mentorship. So that's why that piece is important. Having supervisory experience, including the ability to develop team performance. That's why I think ideally this should not be a newbie supervisor. Although you might have someone that you've had your eye on and you think would really make us do a bang-up job. So it's not to say absolutely that couldn't happen. But again, I think that having had some supervision under their belt would probably be a good thing. This is a person who probably should be able to develop a really solid unit, really good working alliance among their team, and people having a good understanding and a shared understanding of the tasks and processes, because they also need to cover for each other if different people aren't there. So you might focus on people having assignments related to their particular experience and backgrounds, because some people will have experience in particular things more than others, but there should be some cross-training available as well. That usually is helpful. The person in the supervisory capacity should have demonstrated competency in the interpretation of UM metrics. So this is someone who needs to have some familiarity and comfort with data, who can look at data, can be able to explain these data, can explain data to other staff as well, and not to be scared off by data, because the MCO is going to be very data-driven, and it's expected that we, in terms of the world in which we're functioning, will also be data-driven as well. Having a knowledge of MCO outcomes and requirements such as HEDIS measures, things which would be, for example, the number of days following someone's discharge from the hospital, the number of days until their next appointment, their follow-up appointment. That's a HEDIS measure, something the MCOs are tracking. So this person, in terms of their interaction with the MCOs, can certainly explore these as well and be able to be conversant with the MCO on that. That's a really helpful thing as well. The next thing is something we've talked about a little bit, but what's unique to each MCO in terms of their review process. So to get a sense of how it's done for MCO per service as well, because again, looking at the services, some are going to be probably getting more scrutiny than others. So really being able to have that sense, to be advising people about that, that will be a helpful thing as well. And again, when I talk about the culture of the MCO, you know, each one, even if there's some uniformity in terms of that, you know that every company, the same as us as provider agencies, has a somewhat different culture. Get a flavor for that as well, and I think that's helpful. Certainly the next piece would be something for any supervisor, I think, but it can't hurt to say it again, which is to have excellent written and oral communication skills. And that's internally, in terms of any communications they have internally, and certainly in terms of communicating with the MCO as well. And particularly, these are time-sensitive situations, and the particular situations that we find ourselves in terms of speaking about our clients, they can be clinically very sensitive as well. So we want someone to be sophisticated in the way in which they present things, and also to be very focused in terms of that. Some of the conversations with MCOs are not you know, kind of free form. You don't have all the time in the world. So you want to be able to have a sense about your point, being able to speak to it as well, and to be able to focus, and to have other people focus too. Certainly to be self-motivated, to be able to prioritize multiple issues and have excellent organizational skills. So these are people who can multitask and have several, not only they're juggling several things, but some of those things could be on fire as they juggle them, and to be able to do that. And I think one thing in terms of presenting this opportunity to someone is to think that however carefully you may have planned your day as you come in the morning, realize that your day is probably not going to go as you have planned it. So someone has to be comfortable with that level of uncertainty, that there could be something hot that takes its place, something comes up, or you have several of your staff are not in that day, how are you going to be able to cover them? And I think people who've been in those kind of challenging supervisory situations already have some sense of how that plays out. But again, that's the kind of thing to be thinking about, because now it's not only internal, but we're talking about the external customer, i.e. the MCO, involved in that too. The ability to track multiple projects to task and follow through as needed. So this is the multitasking. This is the quasi-project management piece that's a part of that as well. And these are whoever is in this position may have the ultimate accountability to report back to agency leadership in terms of how we're doing with this particular task. So again, to be able to juggle that, to be able to keep on track of it, because leadership can ask at any time, well, what's happening with this? Or we had this particular challenge with company X, how are we doing with that? So again, being able to pull on that and not relying solely on anecdotal information, but some actual data to support those reports would be a very good thing. Okay, we talked about ability to manage and coordinate with internal and external departments. I would say that is really customers, and so customer service skills, as broadly as we wish to interpret that. I think that's important. And certainly the managed care experience, if you are lucky enough to find someone who's done some UM before, that's great, but if someone perhaps has worked for an MCO in some capacity, that's certainly a plus, because they will bring that experience, that kind of insider knowledge into the situation and can help, but very much on a boots on the ground kind of level. Okay, so these were just some general things that we kind of culled out of that very long laundry list that just came before. So this may be a little bit of a summary, but just some things to think about in general. So start off with good clinical supervision and then some. So the good clinical supervision, this is someone who has a good sense of the clinical world, a good sense of all the services that you provide, a good sense of the kinds of people who are getting those services, what their needs are, et cetera. And here's where the and then some comes into play. Supervisors should have, as I was just mentioning, the project management skills, the ability to track things, and the coaching to keep people on track, and the ability to report up on progress with things. So, you know, whatever skills and being able to track those, Excel skills, that would be a wonderful thing as well, because otherwise if you're keeping track of it with Post-it notes, that you're going to lose some along the way, and that you really don't want that to happen. The ability to liaise on multiple levels. So that may be lateral discussion with other departments internally, for example, with IT, because IT has such a crucial role in terms of tracking these things, being able to upload various authorizations, et cetera. If there's been anything that's gone awry, or difficulties, or times when your system's been down and that's interfered, you know, with any of your time frames. So your UM supervisor needs to be able to talk to those folks, as well as communicating with their team, being able to talk with other clinicians, with the leadership as well. So all of that. So this is someone who needs to be comfortable talking with that whole group of people, talking up and talking down, as well as laterally. To develop the consistency of the skill level of staff. So really looking at a uniform approach to work in terms of how we're looking at going about the UM process as well. Being able to bring new people up to speed as well. To be able to do that quickly, assign people according to the strengths that they have. And my thought about that is, for example, people, if you're serving child and adult populations, looking at people who really have a specialty with child. They may have the broader skill, but who are really conversant with that versus people who are really strong in, say, for example, some of your higher intensity adult services as well. People who are very familiar with kind of your basic outpatient benefit kind of skill and service versus more intensive work. People who have skills in mental health as opposed to substance abuse and vice versa. So just in terms of juggling those kinds of things, and you might not be have the luxury to have a lot of staff to whom you're disseminating those different, or delegating, I should say, different responsibilities. But if you are to do that, and if you have a couple of people, just bear those things in mind in terms of how you do want to make those assignments, or for your supervisor to bear those things in mind. The next part is something, again, that I would just say is important, the ability to catch problems and to develop solutions proactively. You really want to have your eyes open and to do that before the MCO does. So if you recognize that there are things that are problems, to realize, was the ball dropped on something? To realize that, to just take ownership of it, develop a plan so that it's not going to happen again, and be able to move forward. And I think that's really important. And the MCO will note if you acknowledge that, and what are the steps so that it doesn't happen again. I think, they recognize that these things happen. So that's, I think, important. The same token, if you feel that the MCO is kind of really picking on things as well, then that may open a bigger conversation with other people at the MCO, with your leadership, et cetera, around that. So being able to think about that from both ends. And certainly the comfort with data collection and analysis. For the supervisor to have crafted a dashboard of the things they need to be on top of, to know what those things mean, to be able, because the idea about having a dashboard is to be able to have that at a glance, your authorizations, where are we on that? And, how are the individual clinicians doing with that? Okay, where are the trouble spots, who's always lagging behind, and to be able to find out why. Are there people who are spending perhaps an inordinate amount of time on things? How can we help them perhaps with time management? All these kinds of things, which are, again, falling in the realm of supervisory skills, but these are the things to think about. I think also in terms of the data collection analysis, among things that I think are areas where the supervisor can be helpful is to be looking at the outliers in terms of your authorizations. People who've been in services for a long time, long lengths of stayers as well, to begin to get a sense, to encourage people to have a sense, why are they outliers? Why are they in services for a longer period of time? Have a sense about these kinds of individuals, because these are the ones that the MCOs are going to pay attention to. You may want to be having people be coached on why is that? Should, in fact, they be stepped down? Are they overdue to be stepped down? Or, in fact, do they need these services, and why? Be prepared for that. To identify folks who are at high risk as well. For example, are they people who have a high degree of recidivism, perhaps with a rehospitalization? Are they people who have a high number of incidents? Are they people who have a significant forensic background? All of these particular kinds of things. And so you have identified these particular individuals. Well, with that particular high level of need, how are those needs being addressed? So that's something that the supervisor can keep on top of, to have a sense of who those folks are, and revisit these folks from time to time as well in terms of what is happening with them, so that these are people where there's kind of a running expertise on these individuals, and how are we doing with them? Do we anticipate particular needs that they would have? Are there going to need to be particular conversations with the MCO that this is an individual who has a particular type of need that we need to think out of the box? Do we need MCO consultation on this particular situation because we've kind of done our best thinking and we're still running into a challenge? So this is where that supervisor can come in and play a very crucial role with these kind of thoughts and conversations. And then generally, we wanted to again talk about these sorts of things, particularly relevant to this role, to use the checklist again, and for the supervisor to be thinking about that. Okay, so what have you been doing thus far? Take a look at that. What are you going to start doing from this point on? What things are not efficient or effective and you want to stop doing? What things will you keep on doing? What things will you integrate? And be innovative, I think. So to start doing, what new ideas do you have? planning for change? What are any of the roadblocks around that? But I think that's important, to use these things as the opportunities for change, and I think that's all about that. And just as we consider ourselves working with the individuals whom we support in a strengths-based way, what can we do in a strengths-based way for our own agencies as well? Okay. I'm going to pause for a breath. I realize I've been speaking very quickly, probably more quickly than I should, and open it up to Q&A from folks, because now I'll actually let you get a word in edgewise. And by the way, you should send your questions into the chat function on the website here. So that's how we can do them, and I can read them out as they come in to share with everyone. We don't seem to have gotten any questions, so I'm not. Right. Oh, here's one. Here's one. Thank you. Do you have any recommendation regarding the longer length of stay cases, a time frame the managed care companies may be looking at for cases to be in active therapy versus step down to a lower level of care? I don't want to hazard guesses on this. Until, we're still waiting on some information from the MCOs here in New York. And again, my experience coming from the inside track is in North Carolina. But this is what I think. I think it would be helpful for you to be looking at your average length of stay in a particular service, and then identify people who seem considerably further apart. And that will vary, depending on the level of service that you have. Versus the basic benefit versus ACT, et cetera. But I think do that, I would frame it in terms, make it relevant, relative to your own population. And look at what you should, it's, I think, a helpful thing in general to see what your average length of stay is in general. And then find out, you're always interested, who's in a shorter length of stay? Why is that? Have people dropped out and lost a follow-up or whatever that may be? Or the longer length of stay. So I would advise that. And then I would think that once you've identified that, and hopefully it's not a whole lot of people, and people just, internally you're going to right away be thinking about, okay, you have some reasons why that person is a longer length of stay, but it would be probably useful to case conference those folks and just say, kind of with the frame, we're going to look at this person. This person has been in X service 3 months, 6 months, however longer, than our average person. Let's look at what the barriers have been to stepping down this person. Do we anticipate stepping them down? What special supports do we need? Do we need any kind of special assistance, et cetera? So these may be some of the most, I would anticipate, these are going to be the most challenging folks that you have. And I will tell you in North Carolina, some of the folks that we saw, and as the MCO, we were certainly aware of these folks because we also knew them in the community as well, that some of these folks often had very significant forensic involvement. Those were some. We needed a lot of supervision. These were people for whom there were concerns about being having community placements, and we wanted to be sure that they had a very strong level of support as well, and who were making progress, but it was incremental, but we saw that, and they were very involved in recovery. They were committed to recovery, but had a number of extenuating circumstances that made their progress more difficult. So those are the kinds of things that I would consider around that. All right, we're going to just move on from our QIA, the what's next kind of thing. We thought it might be useful to just talk about that. Certainly, and oh, we have another question. What was the average length of stay in outpatient clinics in North Carolina? What NUBA qualifies as a long length of stay? Great question. Well, I will tell you what our basic benefit was. And we were able, the various MCOs, we were basically offshoots of government entities doing MCOs. It's more complicated than we even have time to discuss right now, but I wasn't with Value Options, et cetera. I was with MecLink Behavioral Health Services. Our basic benefit, just to give you an idea, this was unmanaged. We had 8 unmanaged visits, outpatient visits for adults, and 16 unmanaged visits for children. After those basic benefit parameters, we would ask for reauthorization. And we would find that many times for the basic benefit that people actually completed treatment in that time frame. And offhand, I cannot recall what our reauth situation was, but I want to say it was probably something on the order of another 8 visits. I'm going out on a limb with that, but reauthing that. And generally speaking, our outpatient folks would need 1 or possibly 2 more reauths, and then usually people had stopped treatment. So that gives you some idea. And these were folks who had, you know, have run-of-the-mill kind of outpatient clinic visits. So we were not managing the pharmacy benefit. So we would have some people who were, you might think might be medication management only kind of folks. We were not working with those particular people. But that was generally what we would be thinking about. So going much longer than that certainly would be a longer length of stay. And because also we were promulgating a cognitive behavioral kind of treatment, which is by its nature more short-term than, say, a more dynamically informed treatment, it was going to be shorter. But certainly there were outliers, again, in there for people for whom issues emerged in the course of their therapy, things that they had not disclosed or been aware of, which made it required that they had a longer period of treatment, or maybe a more intensive type of treatment, or they suffered some kind of setback or challenge or hurdle in their lives during the course of treatment. So certainly we took that into account. We would ask the provider to give that to us. So someone who would send in kind of a bare bones reauth and said, you know, basically, well, they need another 8 sessions of treatment to continue, we would say, let's pen that and let's get more information. So those are the kinds of things. Again, with the MCO, it's not only yes or no. There would be often the hold on a minute. And that's when we would pen the authorization. We would say, we need some more information. Explain this to us further so we can understand that. And, you know, most of the time, the clinicians with whom we dealt were complete and gave us the information, and it was, you know, very positive, and we wanted to work to support the individual. But there were times that either it really wasn't warranted or we couldn't really find the medical necessity. Those were times that we went with denial. But, you know, it was few and far between, I will tell you that. Okay. So in terms of our what's next, one of the things that I had referenced before was that we certainly hope to get some information from the plans in New York State and get that information, and for MCTAC to be able to turn that around and give feedback to you as well. So that's one of the things we want to do when we get that information, to be able to turn that around and to offer it as well. Then we're hopefully looking in early 2016 to have additional learning communities similar to the kinds of things that we have been doing, where people, our audience out there, those would be you, can share experiences, and we can get together from the voices at MCTAC, but also involve you in terms of your experiences, to share those, good, bad, ugly. I hope it's a lot more good than the others, and also to learn from each other on that, and to find maybe are there commonalities in questions or concerns that have come up, and then we can develop a strategy for how we want to address those going forward. So those are some of the ideas that we have for what's next, and certainly we would like you to let us know what you would want from the future from MCTAC as well. What's helpful? Hopefully some of those ideas that I just threw out there will be helpful, but other kinds of things that are occurring to you at this point, and as we move on, once we really get into it, what are the things that are going to be most helpful? Because this is really, we want to be guided by your needs and be able to craft things that will meet your particular needs. And certainly, you know, we have this submitting questions, so this is the best email to use. So they can be in terms of the supervision questions, but certainly I'm throwing it out here to a broader set of questions as well. That can, anything that can come up, suggestions for the future as well, and again, things that perhaps we haven't even touched on, that you in the field and in the trenches, the things that you need, the things that are concerning you now, and the things that concern you as we go live, please send those to us so we can craft a response, or responses, plural, because there'll be several, back to you. Okay, and this is the MCTAC site and all the kinds of things that are going to be available for you to look at. There's video footage, more of our presentations, things you can go back to, refresh yourselves on, all of those sorts of things. Okay, hold on, we had another question. What would you suggest for staff to patient ratio? Again, and again, we really don't have an algorithm for that, and so I'm sorry I can't really suggest that. I don't have, there's no algorithm in the field that we're aware of, so that is something that is a bit play by ear, and I would say that some folks are going to have staff, a large number of staff and a supervisor. Some people may not have that luxury, how many staff that you may have as well. So that is something of a play by ear that may be something that we want to talk about more when we get together at a later date in terms of what solutions people have come up with, what has worked, what didn't. You know, did you have a surplus of people? Did you have enough people? Did you find when you went live that you needed more than you planned for? So I just definitely think that that's food for thought. But I wish I did have an algorithm, but I really don't have something that I can share with you, unfortunately. Okay. So barring that and any other questions, what was the caseload size to clinician in clinics in North Carolina? Trying to think. Generally, and I'm not really sure, I will tell you that the very smallest agencies, we had a lot of kind of mom and pop shops, and sometimes there was not a person in those very small shops. They just could not. The clinicians had to be the major people making the calls, et cetera, and whom we dealt with most frequently would be the clinical or medical director of those particular agencies. Other than that, there would the larger agencies that would be a full-service agency that were doing clinics and ACT and everything else, there would typically be, I'm going to hazard a guess, maybe 3 staff plus a supervisor. So it really depended on size, and I wish I had some more info to share with you on that. I really don't, but that's really what it went to. But I will say that in North Carolina, we were in a little bit of a different situation, because when we went live, our going live was everything all at once, meaning we were doing adult and child, mental health, substance abuse, and IDD all went live on the same date. So we had to cover authorizations on all of those different areas. So it was a little bit different, and the agencies had to kind of step up to it, particularly on the mom and pop shop that I referenced before. That was largely on the IDD side, probably more than mental health and substance abuse, but just to give you an idea. And are there any recommendations with regard to data collection, that was a Freudian slip, and tracking to set baselines? Well, you know, I think you really want to get a handle on the people you serve, how many people you have in your different services, how long they've been in different services. You know, get a load of your, you know, what are your caseloads? You know, how many clinicians are seeing so many people? Those kinds of things. You want to really have a sense of that. Also, do your caseloads, how are they organized? For example, when I think about the turnaround time, are caseloads assigned kind of randomly to the next available clinician, or do you have clinicians assigned to a particular population, or people who are more experienced clinicians have the more difficult ones as well? Because later on, that way, they're going to have a different kind of group of people in their baseline than others as well. So those are a number of the things to look at. But certainly, your length of stay would be a really important one, I would suggest, to start looking at as well, to start with. Okay. So, and other questions that occur to you as you have them, please send them in to MCTAC, and we will get those questions posted and answers out to you. And greatly appreciate your attention today, and great questions sent in. Look forward to talking to you again as we move forward into our brave new world. Take care, everybody.